Hello, and thank you to the chairs of the session, and thank you to my colleagues at the SES for organizing this conference and giving me the privilege of speaking at the session. It is such an honor. The title of this talk is Epilepsy Neuropsychiatry. It's also the title of an entire area of study, but we will try to hit some specific objectives and review some recent literature during this talk. These objectives include presenting a map of neuropsychiatric symptoms in epilepsy and an overview, and then looking at interictal disorders, followed by periictal disorders, and we will unfortunately not go over some of these other areas which are fascinating and worthy. Each of them is worthy of a talk of its own. So the story of neuropsychiatric symptoms in epilepsy starts like any other story in neurology with the lesion. The lesion often resides in neuronal networks that subserve neuropsychiatric functioning and cognition, and therefore they are likely to cause symptoms as well, independent of the seizures. The seizures, however, can lead to neuropsychiatric symptoms themselves, and interictally, neuronal network dynamics are changed in a way that leads to neuropsychiatric symptoms, and neuropsychiatric symptoms themselves can alter seizure frequency. We prescribe anti-seizure medicines to reduce seizures, and these may have cognitive or neuropsychiatric symptoms as well. And the neuropsychiatric symptoms themselves may lead to cognitive dysfunction. And to mitigate them, we sometimes prescribe psychoactive drugs, and these alter seizure threshold and can lead indirectly to worsening of neuropsychiatric outcomes. Non-epileptic seizures are sometimes confusing of seizures and are associated with neuropsychiatric dysfunction, as well as psychosocial stressors in the context of epilepsy. Therefore, there is a complex web of interactions in epilepsy that lead to cognitive and neuropsychiatric symptoms, and we will try to review some of it. All right, so let's begin with discussing interictal affective disorders in epilepsy. It was Hippocrates that said, "Melancholics ordinarily become epileptics, and epileptics melancholics. What determines the preference is the direction that the malady takes." Hippocrates here seems to be aware of the bidirectional association between epilepsy and depression. We now know that they have shared neural circuit pathologies in the hippocampus, for example, that's cingulate gyrus amongst other areas. And we have epidemiologic evidence of this association. It may be easier to understand that epilepsy and its pathologies can lead to can be associated with mood dysfunction, and it may be counterintuitive to think that depression or other mood dysfunctions can lead to epilepsy. But that holds. Epilepsy is associated with a 2 times risk of later development of depression, and depression is associated with a 2.5 time increased risk of later development of epilepsy, as is shown in this hazard ratio graph from this recent JAMA Neurology paper. And if you're admitted for epilepsy, you carry 6 times the risk of being admitted shortly after for mood disorders, implying that something happened in the brain that may put you at risk of later development of mood disorders. Interictal depression is common in epilepsy, with a prevalence ranging from 10 to 40% depending on what study you look at. Major depressive disorder in specific was found in 22% of people with epilepsy in this meta-analysis. And it may be of interest in this international conference to note that the prevalence seemed to vary according to continent, with North America having the lowest prevalence at 15 or 16%, and the other countries hovering between 20 and 25%. There's less heterogeneity in North American studies, but there may be cultural or healthcare system factors associated or explaining this variance. There are risk factors for developing interictal depression, and these are some of the usual suspects, including older age, female gender, lower educational and socioeconomic status, poor adherence in polytherapy, along with longer duration and higher seizure burden in epilepsy. And depression may present differently in epilepsy from its typical presentations. And this may be due to the paroxysmal and different neuronal dynamics seen in epilepsy from what is seen in idiopathic depression, as well as the clinical context of epilepsy and its treatments. Depression in epilepsy deserved the term interictal dysphoric disorder, which was first coined by Kraepelin and popularized by Bloomer. And in addition to the typical depressed mood, there's a certain lability to the presentation, as mood tends to vary from low mood and anergia to all the way to irritability or even euphoria. There's also an emphasis on somatic symptoms, including insomnia and pains in the context of epilepsy. Therefore, the interictal dysphoric disorder of Bloomer is somewhat distinct from what we see as a DSM diagnosis and represents an overlap of different categories seen in the DSM. And here is an additional reason for us to care about depression in epilepsy. It doesn't just lead to poor quality of life, it also leads to worse seizure outcomes. This is from a recent meta-analysis in JAMA Neurology showing that the presence of depression and the treatment of depression is significantly associated with poorer seizure outcomes and failing to achieve seizure control at 1 year. Again, pointing to the bidirectional relationship between depression and epilepsy. All right, onwards with interictal anxiety. Anxiety is also common in epilepsy, arguably more common than depression because of the breadth of symptoms that you can have in the different anxiety disorders. Here is a recent cross-sectional survey that showed that up to 35% of people endorsed worrying thoughts, whereas a similar range of percentages were reported for the other components of the anxiety scale. And when you look at specific anxiety disorders, you notice that phobias and panic disorder take the lead with a percentage ranging from 5 to 7%, with generalized anxiety disorder coming next, and OCD and PTSD coming after. And here are some of the usual suspect risk factors for having anxiety in epilepsy. You'll have some seizure and epilepsy related factors, and some sociodemographic factors, stigmas in there, once again, just like it was for depression. And then there's a bunch of psychological traits like a external locus of control and neuroticism and so on and so forth. And the quality of evidence here is poorer than we have for depression. So let's move on to interictal psychosis in epilepsy. And here's a glance at this meta-analysis of first of all, look how many studies there are of psychosis in epilepsy. And the meta-analysis shows that there's a 6 times increased risk of psychosis in comparison to the general population, and 7 times the general population in people with temporal lobe epilepsy. And even though psychosis is less common than depression and anxiety in people with epilepsy, it has a significant clinical impact and has been of interest to healthcare professionals in the area for years. And even though you can have various psychotic phenomena ictally and periictally, interictal psychosis is actually a distinct syndrome with still a wide variety of psychotic symptoms. It may look just like schizophrenia. It may exhibit what we call Schneider's first-rank symptoms, which are symptoms that are typical for primary psychotic disorders. It oftentimes has an affective component to it, so it's closer to a schizoaffective syndrome than to a schizophrenia. It is less likely to have the negative symptom aspect of schizophrenia, where people are withdrawn and possibly catatonic. It may respond to smaller doses of neuroleptics than is typically required for schizophrenia. Chronic interictal psychosis is a distinct syndrome, like I said, and it is given the name schizophrenia-like psychosis in epilepsy. epilepsy. And there's a strong and well-known relationship between psychosis and epilepsy, presumably because of the reasons we mentioned earlier of shared underlying localizations and pathogenesis. Who is more at risk of getting interictal psychosis? Those with longer epilepsy with a higher seizure burden. There's some association with intellectual disability, although this is inconsistent. History of febrile seizures, and one must consider the role of anti-seizure medications and the process, theoretical process of forced normalization as a cause of interictal psychosis. And with that, we are done with our discussion of interictal symptoms, and I'm going to use this seizure that we see here in the right hemisphere to transition us to ictal and periictal neuropsychiatric symptoms. So dividing neuropsychiatric symptoms and a lot of other concepts in epilepsy according to the stages, interictal, early ictal, and post-ictal, has stood the test of time since the days of Yule and Jackson. You have the interictal symptoms, which are pervasive with no clear relationship with seizures, and the example for that is interictal dysphoric disorder and the schizophrenia-like psychosis in epilepsy. You have premonitory symptoms, which are changes in mood, irritability, or anxiety that are seen 1 to 2 days prior to the onset of seizure. Parents will often can tell that their children are going to have seizures a couple of days before because of these changes. And then there are the true periictal symptoms. These are symptoms that are the ictal symptoms are associated with epilepsy or are associated with seizures temporally. They are episodic, they have clear onset, clear offset, are typically shortened duration, typically lasting minutes. They are stereotyped, they are intense, they are not triggered by emotional stressors, and they are purely neuropsychiatric in nature. And as much as 20 to 30% of our auras are neuropsychiatric in content. There may or may not be an altered sensorium with these ictal neuropsychiatric phenomena. Or an altered awareness. It may be a true focal aware seizure. Panic is certainly perhaps the most common. Depression and depression-related symptomatology is not common, seen in less than 10% or representing 10% or less of the neuropsychiatric auras. And it's different from the depression that you see interictally. It's an intense feeling of dysphoria, guilt, sometimes forced negative thoughts for a very brief and distinct period of time. Disgust is also something that is sometimes associated, there's a lot of interesting discussions that are an area of study of how to learn emotional neuroanatomy from seizures. Ictal psychosis is also something that is seen, although less common than panic and anxiety, which are by far the most common. Post-ictal neuropsychiatric symptoms follow seizures with or without a symptom-free or a lucid interval after seizures, and typically resolve hours to days after the resolution of the seizure proper. You can have a range from psychotic symptoms with delusions and agitation, irritability, and oftentimes there's a mood dysregulation component to them as well. So let's give a little bit of time to ictal panic and idiopathic panic attacks and how one can differentiate them. And it is also striking the overlap in semiology between them. Both are distinct with clear onset and to a certain extent clear offset, and are episodic and are sometimes tend to be, even idiopathic panic attacks can be independent of external emotional stressors and so on and so forth. But one can differentiate between them if you take a careful history. Idiopathic panic attacks are longer, can last 20 to 30 minutes in comparison to ictal panic, which is briefer. People are immersed in these panic attacks, which are dramatically intense. And even though we see in our EMUs patients with dramatic presentations, I remember a patient that we just had the other week with who suddenly started yelling, "My father, my mother, my cousins, please God protect them," and before she went into a full-blown focal awareness impaired seizure and then a convulsion. Even though we do see these things, idiopathic panic attacks are typically more dramatic. Both have autonomic hyperactivation, although excessive salivation seems to be more specific for ictal panic and rarely seen in idiopathic panic attacks. You have a lot of psychomotoric hyperactivity with idiopathic panic attacks. People can get up and try to get away and hide themselves, or tend to rock in bed. And this sometimes is confusing with automatisms for the novice observer. People may progress with ictal panic to loss of awareness, and people with idiopathic panic attacks don't, but can have a dissociative feeling because of the intensity of the anxiety. And even though ictal panic is not associated with emotional triggers, reflex epilepsy can be considered sometimes in some cases, although not typically, with temporal seizures that are associated with panic. Idiopathic panic attack can be also completely random, but it can also be associated with specific phobias or agoraphobia, which is a big clue here. So the message here is that TLE may masquerade as panic disorder, and it is estimated that 20% of people that are diagnosed with panic disorder will have epilepsy later on, or will have had epilepsy later on. And anxiety in epilepsy may be mislabeled as seizures because of the pre-existing diagnosis of epilepsy, even though anxiety is common in epilepsy. Epilepsy remains a window into the brain and the understanding of underlying emotional neural circuitry. This is our typical ictal spect and interictal spect, showing the large area of ictal hypermetabolism and hypometabolism interictally in the involved temporal lobe. And this is a synopsis of functional imaging of panic disorder, showing not just involvement of first of all, showing a smaller area of involvement of mesial temporal structures, the amygdala specifically, but also showing hypofrontality as a marker for trait anxiety. What about ictal psychosis? Ictal psychosis can have many forms. Simple or complex visual or auditory hallucinations are an example. Seeing a beach ball flicker around, or hearing noises, or hearing words, or somebody calling, all the way to complex hallucinations that the conscious person can put interpretations on them. Most recently, we had a patient who was diagnosed with PTSD and anxiety disorders by his psychiatrist, but was also later found to have a glioma, had a glioma resection, and the entire gamut of symptoms that was dubbed primarily psychiatric resolved. And the literature is full of situations and case reports like that. In addition to that, people can have confusions, delusions, ideas of reference involving indicating involvement of salience detection networks, and even forced thoughts for distinct periods of time. We're now discussing, don't forget, we're discussing ictal neuropsychiatric symptoms. Oftentimes, though, when you look at studies, the word psychosis is poorly defined. In the late 80s, Rohr, LeFloc, talk identified three major types of what we call ictal psychosis. One is sort of negative. They call them absences, oftentimes presenting with a certain degree of indifference, withdrawal, being perplexed or mute, somewhat looking catatonic, even though the word does not fit here. The second type is one that is more outwardly, with delusions of persecution, a little bit of anxiety and irritability, and aggression, in addition to the negativism previously described. The third is has a pleasant nature to it, with smiling and hilarity and confabulations. And sort of this is, as you can see, it doesn't really always adhere to what we think of when we say psychosis. The interesting point here is that these symptoms may last 4 hours, with either happening in smaller episodes or fluctuating over a period of hours. And this was documented using intracranial EEGs. There are a bunch of reports out there of people becoming psychotic while getting intracranial recording, and you can look at the gamut of symptoms that people report as being associated with EEG changes: stickiness, aggressivity, dysphoria, internal dialogue with voices, Capgras syndrome, and so on and so forth. And it continues to be of interest whether ictal neuropsychiatric symptoms may become prolonged, and whether seizure pathology may underlie some of our psychiatric psychiatric syndromes seen and labeled as idiopathic psychiatric disorder, even though in practice this is rare. We do know that aura can continue for prolonged periods of time. We don't know that absence status exists. We do have the term aura continua. And when you look at the gamut of neuropsychiatric symptoms that can be seen in non-convulsive ictal states, this is from a paper a few years ago by Peter Kaplan, you will find neuropsychiatric symptoms in whatever localization you look at, and we are very familiar with this. So we work with our psychiatric colleagues in order to discern where it is appropriate to apply scrutiny, and we still think it's rare in practice. All right, and let's move to post-ictal neuropsychiatric symptoms. And we're not here referring to what we typically see after a convulsion, say, for example, when people get agitated or delirious for a period of time and improve gradually. We are referring to a whole gamut of psychotic or mood symptoms that are seen post-ictally. People can get manic or depressed. People can get delusional or even aggressive. And the key here is to decide whether there is a lucid interval between the termination of the seizure and the beginning of your neuropsychiatric syndrome. If there is, then you so there's a clear return to baseline, then this fulfills criteria for being post-ictal syndrome, so-called nuclear post-ictal psychosis. Sometimes it's harder to discern, and patients always fall on a spectrum. If there isn't a return to baseline and people sort of emerge from their seizure into the psychiatric syndrome, then one must worry that whatever neuropsychiatric syndrome they're seeing is actually ictal with underlying seizures that aren't that may or may not be seen on EEG. So this is important to determine. We are faced with two situations: a cluster of seizures with lucid interval with subsequent emergence of your post-ictal psychotic symptoms. And we presume the physiology here to be Todd's-like hyperpolarization. Whereas if seizures continue and without clear emergence and return to baseline, we may be dealing with post-ictal psychosis. All right, we're close to finishing. Final notes on management. We can use antidepressants to treat neuropsychiatric symptoms in epilepsy. We're relying mainly on evidence from mood disorders, idiopathic mood disorders, and with extrapolation, there's also some evidence for some of the SSRIs and SNRIs in epilepsy. There isn't a lot of evidence that they increase seizure risk, antidepressants, and they are generally safe, but one must be cautious with some of them, like clomipramine and immediate release bupropion. Antipsychotics can also be used. Some of them, especially the older generation, may increase seizure risk. Clozapine in particular is associated with a high reduction of seizure threshold. Olanzapine, quetiapine, risperidone are a little safer. Drug-drug interactions must be taken into consideration, as our enzyme-inducing agents may lower the levels of psychoactive medications, and a few of our psychoactive drugs are enzyme inhibitors. One must not forget non-pharmacologic therapies, since there's evidence that they work even if we think the disorders we see are linked to a so-called organic syndrome. And here are our take-home messages. There are a myriad of neuropsychiatric processes and phenomena in epilepsy that affect mood, behavior, thought, and cognition, and we showed the map earlier in the talk. Depression is common in epilepsy and has unique presentations, and the so-called interictal dysphoric disorder embodies them. Depression in epilepsy may be associated with worse seizure outcomes, not just poor quality of life. Anxiety is common in epilepsy, and its risk factors are many and are incomplete understood. Ictal neuropsychiatric semiologies are common and present a window into neural correlates of behavior. A better understanding of these phenomena may improve seizure localization and care for psychiatric patients as well. There's a spectrum of post-ictal neuropsychiatric phenomena. Lack of a lucid interval after seizures increases the likelihood that these phenomena are in fact ictal. Systematic screening, diagnosis, and appropriate management of neuropsychiatric symptoms in epilepsy is of significant importance. And once again, there is no neurology without psychiatry and no psychiatry without neurology, and the two are faces of one coin. Thank you very much for listening. I enjoyed giving this talk, and it's a privilege to be here with you. Thank you very much.